Thoracic Anatomy. Thoracic cage consists of 12 pairs of ribs, 1 to 7 being true ribs and 8 to 10 false rib, and 11 to 12 are floating rib. The thoracic vertebra and the sternum. The first rib is the shortest and the flattest, and the superior surface features the grooves of the subclavian vessel separated by the anterior scalene muscle. The artery runs posterior to this muscle along the brachial plexus, while the vein runs anterior, and the head of each rib articulates with its corresponding vertebra, and the one superior exception is 111 and 12, which articulates with single vertebra. The sternal angle of Lewis between the manubrium and the body provides the important landmark for the second intercostal space for the aortic arch and the tracheal bifurcation. And T4, the intercostal neurovascular bundle runs on the undersurface of each rib, and the intercostal artery supplies the posterior and the lateral chest wall, and the arteries of 1 and 9 combine with the internal mammary arteries to supply the chest wall anteriorly. The distal arteries 10, 11 and subcostal artery supplies the anterior abdominal wall. Intercostal vein drains into a hemiazygous vein into the right and left side respectively, and intercostal nerve exits the spinal canal via the intervertebral foramen and provide a chest wall with sensory and motor innervation, and also convey the fibers of sympathetic chain. There are 3 layers of the intercostal muscles: external running inferior medially, internal running superior medially, and the innermost. The overlying these layers are muscles of the upper extremities, which may be divided during thoracotomy, used for the thoracic reconstruction and buttressing. These muscles include pectoralis major, latissimus dorsi, serratus anterior, which are used in reconstruction also. Other important muscle is trapezius, and the floor of the thoracic cage formed by the diaphragm, which is very important. The parietal pleura is attached to the inner chest wall by endothoracic fascia, which allows the elevation of the pleura and avascular plane, and the parietal, costal, mediastinal, and diaphragmatic and visceral pleural transition at the pleural recess of the hilum and along with the inferior pulmonary ligament. The diaphragmatic pleura is thin and inseparable from the diaphragm, while superiorly the pleura is supported by thickened endothoracic fascia or Simpson's fascia. This provides some protection to the pleural spaces and may extend several centimeters above the clavicle, and the inferior reach of the pleura is generally on the 1 interspace below. The lungs are divided into lobes and further divided into bronchopulmonary segments. Bronchopulmonary segments are self-contained selection of the lungs of their own dedicated bronchial vascular supply. The right lung has 10 segments: right upper lobe, apical, anterior, posterior, medial and lateral, superior, anterior, basal, posterior, basal, and medial, basal, and lateral. The left lung is similar, but 3 major exceptions. The lingula takes place of the middle lobe, but is a part of the upper lobe, and the upper lobe apical posterior segments are usually combined with the anterior, medial, and basal segments of the lower lobe combined, and this leaves the left lung in 8 segments: upper lobe apico-posterior, anterior, superior, lingular or inferior lingular. Lower lobe is superior, anterior, medial, basal, posterior basal, and lateral basal. Bronchial anatomy of these segments is most common consistent, while the pulmonary arteries that run with them at the center of each segments and more variable, and the veins run separately by intersegmental plane. The trachea is approximately 11 centimeter long and has 17 to 20 rings. The right pulmonary artery runs anterior and inferior to the right main bronchus, traversing the junction of the major minor fissure. Since the right main bronchus courses superior to the right pulmonary artery, it is said to be epiarterial. And the first branch of the right pulmonary artery, the truncus anterior, arises before it enters to supply the right upper lobe, and the upper lobe may further supplied by the posterior ascending branch entering the inferior space of the lobe posterior to the superior vein, where it is risk of injury during the vein dissection. The superior segmental artery arises posteriorly to the level of the middle lobe artery. The left pulmonary artery is a direct continuation of the main pulmonary artery beginning anterior superior to the left bronchus before wrapping around posteriorly, and since the left main bronchus travels inferior to the left pulmonary artery, it is said to be hypoarterial. The left upper lobe has most variable arterial anatomy and the anterior branches, and which is multiple, wide and shorter, and hidden by a superior vein, at most the risk of injury from the lobectomy. The number of pulmonary artery branches of the left upper lobe vary from 2 to 7, and most commonly the apico-posterior and the anterior segment receive the blood supply for the apico-anterior trunk. In some cases, the arteries for the apical anterior and posterior segments originate separately. The left upper lobe can also be supplied by posterior branches that arise from the inner curve ongoing the pulmonary artery. In most cases, the lingula is supplied by one branch of the pulmonary artery, which gives off arteries for the superior and inferior segments, and the continuation of the left pulmonary artery that supplies the left lower lobe may be called as the interlobar artery, from which branches to the superior segment, inferiorly lingula, and the basal segments are often given off. The superior pulmonary vein drains in the upper and middle lobes and the right upper lobe. For the lymph node are very important for the staging purposes. The thoracic lymph node are divided into pulmonary and mediastinal regions, and though in reality these node stations are in some physiologic continuity and only separated by short distances. So mediastinal nodes are noted along the single digits 1 to 9. The highest mediastinal lymph node is 1, upper paratracheal is 2, prevascular is 3, and lower paratracheal. The subaortic or pulmonary window nodes are 5, para-aortic nodes are 6, subcarinal nodes are 7, paraesophageal nodes are 8, and inferior pulmonary nodes are 9. Pulmonary nodes located within the reflection of the visceral pleura are noted in higher digits from 10 to 14, include hilar 10, interlobar 11, lobar 12, intersegmental 13, and subsegmental 14. Annual nodal involvement includes the ipsilateral pulmonary nodes, and if involved, mediastinal nodes to the ipsilateral nodes of the tumor, the nodal staging N2, whereas the contralateral involvement is designated as N3 disease. The thoracic duct arises from cisterna chyli in the abdomen and passes through the aortic hiatus in the chest. It rises posterior to the esophagus in the aortoesophagus groove until T4, T5, where it crosses and runs in behind the innominate vein and drain into left subclavian internal jugular vein. The phrenic nerves provide motor and sensory innervation to the diaphragm. They descend over the anterior scalene within the facial sheath and enter the thoracic inlet between the subclavian arteries and brachycephalic veins. Vagal nerves conversely run posterior to the hilum, and the recurrent laryngeal nerve branches from the vagi to ascend along the tracheoesophageal node, and the left nerve, which runs around the ligamentum arteriosum under the aortic arch, is high risk of injury due to thoracic operation at the right, and which runs around the right subclavian artery. And during mediastinoscopy, the left recurrent laryngeal nerve is particularly at risk with the use of cautery, and therefore should be avoided when dissecting on the left side on the airway. Thank you very much.